No pressure. No, just kidding. But thank you. You know, I was listening to Anisha speak, and although she doesn't work for the same organization as Michael and I think her voice echoes really a lot of the feelings and impact that our team members are going through this COVID pandemic. And, you know, in my introduction, it talked a lot about how my focus is on strategy and helping my administrative team, you know, grow our programs. And I'll tell you more about that later. And really, our focus, Michael and I, has shifted really 100% to supporting, staffing, ensuring our team members are safe, and helping them cope in the real time. And then of course, as we move forward after this is over, how do we ensure that they're able to go down this path of recovery with us? So we're focused on everything from ensuring we have the right staff and able to move our staff around, which we'll talk about, providing spiritual, emotional resources, helping the community get involved, showing that appreciation for team members so that they know that we're with them. And you've seen a lot of that in the news and in the media, and making sure they're safe and have the proper supplies to provide the best care. So that's really where our focus has shifted and my focus has shifted. And on a personal note, you know, you really want to be there and present with your team and help them. But prior to our mask mandate, I also became COVID positive. So I was tested, I had to recover, I had to quarantine, and being away from the operation for that time, although I could still do work, it was challenging, but I really wanted to get back and make sure that I was able to help care for our team members and our patients. And I think the final thing I would say in how my job changed and hearing Anisha was around our team members coping, because people go to medical school and nursing school because they want to help people get better. And really being present and watching them in action and seeing them go through this is really tough and challenging. And you hear the stories because, you know, we can't have that many people in the hospital, so visitors can't come and things of that nature. So we're really the people that are there with the patients, holding their hand, connecting them with their family, and, you know, just being witness and supporting that and caring for the people who are caring for these people has really shifted through this pandemic.
Thank you, Irene, for sharing, and we are glad to see that you are on the other side of this, having been recovered. That is great, great news. Michael, why don't you share with us your insights for the past 2 months?
Sure. 2 tough acts to follow, let me say, first. But totally happy to share this with them. My experience has been very similar to Irene's, right? Being that we're both in human resources as hospital administrators, but prior to COVID, our approach was very strategic, right? So long view, how are we going to help the hospital reach its goals in the future? How are we going to help identify talent, overcome certain challenges? How are we going to build and develop that talent? And as soon as this hit, we went from the strategic lens right back to the transactional lens, which is something in HR that we're trying to move away from, right, as a business. And we began to be hyper-focused, as Irene said, on how do we get staff in the door, right? There was no playbook for this. We use the acronym VUCA, volatile, uncertain, complex, and ambiguous, a lot in HR. This was a perfect example of it, right? This situation was volatile, uncertain, from day to day, hour to hour. We had no idea what was going to happen next. And so we really had to go back to the basics of HR and figure out how do we identify people with the skill sets that we need and either bring them into the organization or find them in the organization and redeploy them. We had surgical techs from our operating rooms that were closed down, taking iPads to our patient floors and showing patients how to FaceTime with their loved ones before they were getting intubated, right? As they were desatting and their oxygen levels were decreasing. So we really took advantage of our skill sets and sort of moved people around to deal with this crisis, because just like Anisha was talking about, we too were at double capacity. We're a 583 bed hospital, and we had over 900 patients at the apex of COVID in about, I would say about a month ago, right? So around April 9th or so. And at that point, I would say 98% of our patients had coronavirus. So really just focused on getting the tools and resources that our staff needed, and then also making sure that our processes and our laws and regulations were enforced consistently. Folks that needed to go on leaves of absences, folks that had restrictions, that we enforced those regulations and rules consistently to treat everybody fairly according to our processes and laws. And now that things are starting to sort of flatten out again, we're thinking more strategically about how do we face the challenges in front of us about returning back to normal, and what does that look like?
Thank you, Michael, for sharing. I thank all of you for sharing what it's been like and giving us a little insight of what your world has been like in the last 2 months. I am going to continue with some questions that are specific to each of what your expertise are, and then we'll move on from there. I'll start with you, Anisha. Can you just talk to us about what are some of the most important myths and facts about COVID-19 that you'd like to share with us?
So the first one is the virus real? Yes. There is no way I'm going to deny it. Do I know more with the genome and stuff? No. So every day, you know, I became obsessed with this. So I go with every conspiracy theory that's out there. I listen to the podcast. I listen to every expert that's out there that, you know, I possibly can. So that's, is it like flu? It's nowhere near like flu. It's affecting lungs in a way like high altitude sickness, which would be your body has oxygen, well, high altitude you have less oxygen, but your body's not able to bind to the oxygen hemoglobin. So no matter how much oxygen we give it to the patient, their blood oxygen saturation still stays low. So that part scientifically, we don't know why that's happening. There is so much more that we need to know. So the fact is that this is a new type of virus. The way it's affecting the human body is different from one person to the other. It's not like a standard diseases that we're used to, and we develop protocols. So it's like, oh, you treat high blood pressure with this medicine. If patients' lungs are this, you know, moderate amount of bad, you put them on this ventilator settings. None of those things are real anymore. So like I said previously, if one medicine and one setting will work for one patient, will not work for the other, or a part of it work for. So this is something we're dealing with completely new. And there's gonna be a lot of more research and studies, and all the knowledge that we have gathered need to be come together to figure it out, that what is actually happening with the body. There's certain type of population that is more prone to it. Besides the age, I've noticed, like, so we have about 50% of respiratory therapists who got sick, and more or less they all had some sort of heart conditions. So like high blood pressures or something with heart. And the research also shows that there is certain type of receptor that's activated, and virus is more prone to binding to that receptor. So that's one thing. And the other thing is, we don't know what is causing the severe inflammation. So the lungs get all filled with fluid. And then majority of our younger patients who were in their 40s did not have any medical history. So the young people were not getting notion was, I think, very much in the beginning, but you know, later on it was all gone. And the most heartbreaking part was a lot of these younger people without any medical history actually died. So that was something, it's very hard to get over, because you're not used to seeing someone who has absolutely no medical history or condition, and we can't do anything about it. So young people are getting it. One thing I don't know for fact, and that's also because we are not testing it, that there are people who are asymptomatic and might be a carrier. How do we know? I don't know, because And whomever's saying it, I don't know why they're saying it, because we're not testing people. How are we saying that there might be people who are carrier and they're asymptomatic? That's just in theory of like epidemiology and pandemic. It's just in theory. But with this virus, because everything is new and there is the high level of uncertainty, it's kind of hard to say what is what without any scientific research or articles that's gonna come out. So that's that. The myths, what are the myths? I don't even know what people, is 5G causing the virus? No, 5G is not causing the virus. What I understand that, 5G is definitely high radiation. It's just a common sense to me that, 1G, 2G, 3G, 4G, obviously high radiation. High radiation affects the body's immune system, right? That we know that much. What we don't know is that how much of 5G is gonna affect the human body. Because the bandwidth can go from 1020 to 60, and is the government gonna allow that high bandwidth that's actually gonna affect human body? So 5G is definitely not a direct cause of COVID-19. What else? Does vitamin C helps? Absolutely. If you are already working on your immune system on a daily basis with proper nutrition, vitamins, minerals, zinc, vitamin D, then your immune system is already strong and it's building up. If you're gonna start taking today of thousands and 10,000 dosage of vitamin C, it's not gonna help, right? So that's not gonna prevent, because your immune system is not built up. So taking these vitamins on a daily basis is helpful, but if you're gonna get the virus and you're just gonna take high dosages, I don't think that's gonna help right away. Maybe in future it will build up the immune system. What are the other myths that I can think of? Oh, mask certainly helps, especially in a closer proximity. So this virus is droplets. So talking, laughing out loud, it can actually go. It's like water droplets, tiny, tiny water droplets. So if you have a mask over it and you are the carrier, it's gonna be less likely the other person who's standing, a little bit further away are gonna get exposed to it. If someone's so close to you, even with this mask, there is very, very minor chances it'll get through the mask, because these masks are not N95. Those are just regular surgical masks. But does it help preventing, if you're the carrier, to giving it to the other people? Absolutely. The mask will decrease the amount of aerosolization that can go in distance. So masks are helping. Oh, one thing that I absolutely am requesting people. I'm hoping that their government is not saying go out with gloves, because in a hospital, we're not allowed to walk with gloves in the hallways. We are only allowed to wear them when we are taking care of the patients. With gloves, there is such high tendency to spread it, because once you have the gloves on, psychologically, you're not conscious of what you're touching, because in your mind, you think that my hands are protected and you just touch stuff. But then what if somebody else comes after you, not aware of, touching elevator doors and all that with gloves? So please don't go out with gloves. That's just my common request. But my mom was telling me that the government is saying go out with gloves. I haven't heard it, and I hope they're not saying that, because our infection control department is saying, please do not walk around with gloves, right? Because you don't want to spread. What else? The food is not the common, there is no research or data showing that, you transmit it through the food. Surfaces, definitely, like elevators or, any common community surfaces, if you touch, just washing hands with soap and water is ideal. If you don't have access to it, 60% or higher alcohol content hand sanitizer. So that's gonna help. What else? And it's human to human transmission. So there is no research or data showing that you could transmit to your pet or your pet can transmit to you this COVID-19. I think that's all comes in my mind with the the facts and the myths, unless anybody have any particular question that, maybe if I can answer.
Well, I think we're going to ask the questions after everybody has spoken. And, but thank you for that, because you gave some great myths and facts, especially about the gloves, especially about the gloves, because so many people are outside, wearing gloves. So, which we don't realize that it makes for more cross-contamination.
Right.
Oh, well, thank you for that.
You're welcome.
And just one more question for you before we move on. Could you just explain some of what a typical day is like for you during this pandemic?
So you want to talk about the peak time when it was like really crazy. So we had like really crazy weeks for 2 weeks, the last week of March and the first week of April. So our day starts, we start our shift at 7 o'clock with the shift report. So night shift gives a report to day shift. We eat the breakfast for 15 minutes or depending on, how the day is going. Then everybody goes to their areas. They assess their patients, check on them. We make sure all the ventilator settings are the way it's supposed to be that we got on the report. We suction the patients. If anything needs to be changed, we change them. So we pretty much do the patient care for, let's say, depending on how many patients we have, it could be anywhere from 2 hours to 3 hours. Then we'll go back to the computer and enter all these data. So we'll chart. And by that time, it would be, let's say, 11 o'clock. Because right now, because we have so many ventilators, there's other small things that we used to do. We're not doing them anymore. So like giving nebulizer treatments, the nurses do it for us. So that part is not that we don't have to do. So by 11 o'clock, everyone will kind of sit down, or if they have to go to a transport, they have to take a patient to CAT scan or dialysis or ultrasound, people will do that. At 11 o'clock, people will take a like little snack break. And then they'll go back to their units again, check on the patient. So this is our second round, and do the same thing all over again, just a little bit less than the first round because you've done majority of the work in your first round. Go back and chart again because our charting is like majority of our time that we spend on the computers. So all the numbers and the data will enter on all of our patients in the computer. Then people will eat between 1 to 2. And then from 2 to 3 is our usual downtime in respiratory. So if you don't have anything happening, if no emergencies or no one's going on a transport, people get to take a little rest between 2 and 3. And 3 o'clock, 3:30, you'll start again, your third round, go back, check on the patients. By this time, we will be also doing like a wrap up to make sure we have enough supplies for the night shift. We have water running, our circuits are clean, or anything that needs to be given to the patients that's there. But in all this in between, there is constantly emergencies. So they usually say rapid response or cardiac arrest overhead, and everybody will just run to that. Nowadays in pandemic, because the units are isolated, not everybody have to respond. So we kind of pair up, like, if you're covering 3 and 4, then, person from the bottom and the one from the top comes, or if you need more help, then, text us, somebody else will come and help you. So we don't want to spread the COVID. So we also have non-COVID areas where only non-COVID people will go. So we don't go from COVID to non-COVID to decrease the risk of infection. And then by 4 o'clock, once they're 4 or 5, they're done with their third round, gather their numbers and enter them in the computer again. Will be like 6 o'clock or so. 6 o'clock, most people will wrap up. Then the night shift comes at 7 o'clock. They will give a report and then they will go home. My day as a supervisor, I just do a lot of audits. I make sure everyone's documenting properly. I go through a lot of blood gases, and I make sure all the appropriate care that has to be given to the patients are given. So I'll speak to the attendings, I'll speak to the physician assistants, whomever I have to when RTs bring up the concerns to me. A lot of times I tell them like, hey, I noticed this, can you just go and check? Can you double check? I see you missed this on your charting. So half of my day, I do a lot of audits and I do a lot of data collection because I like the research project. So we have different devices. I collect every day who's added and every day who's discontinued. I have like Excel spreadsheets, and I love spreadsheets. So that's my days like, and I go with my director to bunch of other meetings that we both have to go. Most of the time we split because it's only 2 of us during the daytime. So he'll go to some and I'll go to some of the meetings, and I do not really like a lot of meetings anyways. It bores me to death if it's not something clinical. So I said, you know, I'll go to clinical meetings, you go to the administrative meetings, and that's how my days as a supervisor.
Thank you for sharing that with us, especially giving us an insight of what a therapist goes through every day, along with you being a supervisor. So I greatly appreciate that. And now the questions are going to be geared towards Irene and Mike. They're going to be presenting together this evening. And what I want to ask the both of you is, how have your hospitals supported heroes like Anisha and prepared for the surge as the wave began to hit?
Before you jump in, a thought came to mind about a myth. It's related to PPE, personal protective equipment. Anybody out there who has an N95 mask for home use, number one, make sure that it is an actual legitimate N95 mask. Number two, if you're wearing your N95 mask and you have a beard, your N95 mask is not actually working like an N95 mask. N95 masks are supposed to have a tight seal to your face. For us healthcare professionals, we go through a process to have that tested and make sure that that mask has that seal around our face. So those of us that wear that daily usually have a ring, right, around our face at the end of the day. From that seal happening, and it's meant to not let anything into the mask. That seal is important for it to function. So if you do have a beard and you want to understand how to trim that, I had to trim mine. There's an infographic from the CDC and NIOSH about approved facial hair trimming to wear with a mask. And so it's really important that if you're doing that, you make sure that you have that appropriate seal around your mask.
Very helpful. Thank you, Mike.
Sorry, Irene.
No, that's okay. I think one other thing too is if you're really sick and it's not COVID related, you can go to the hospital. So, you know, some people are really, really scared to go to the hospital, but as Anisha mentioned, there are COVID and non-COVID areas and protocols and protections in place. So if something is really wrong with you, you can go to the hospital.
Yeah.
Great.
Actually, I did have that number and I kind of forgot. So in the beginning, like mid-April, our emergency room and the ambulance services, they were saying that if they were getting 200 calls, let's say, for the cardiac arrest in the neighborhood, like, you know, in the whole Queens, it went up to 700 calls a day. That is crazy amount. So people were so scared to go to the hospital despite having like chest pain and shortness of breath. I actually had to yell at my neighbor to go to my hospital. He was having such shortness of breath. He still waited one day and I said, no, you gotta go. So people were so terrified that they were gonna get more sick in the hospital, and a lot of people were dying at home.
Yeah, and know that there are other options for care. So you can do telehealth, you can do other things if you're not feeling well, to get a consult without having to go to the doctor's office. But even if you go to the doctor's office, for example, they may have you wait in your car until your appointment comes, and before you walk in, give you a mask. So there are things that they put in place to make sure that you are safe.
That is great. Thank you for that information.
Sure. So, so Mike and I were going to we'll go quickly through just some things that we're doing to support our team members from all aspects, and go into a little bit more about the staffing and things of that nature. So, okay, hold on, let me see if it'll move. Of course. Even though there we go. So just quickly, Northwell Health is the largest private employer in New York. We have more than 70,000 team members, 23 hospitals. And if you see the little picture here with the two little circles, the first one toward your left is where Michael works, and mine is out east in Bayshore, and that's Southside Hospital. We have a research facility. We have our own core lab, which we'll talk about in a minute, our own central sterile, and you can see some of the metrics in regards to our operating statistics. So I work at Southside Hospital, like I said, which is out in Bayshore. We are a tertiary facility in Suffolk County that's on a growth trajectory. So this hospital was a community hospital and quickly became a tertiary. So we're on the path to becoming the same size as Michael's, but it's definitely a journey and a few years in progress. So you can see some of the stats in relation to our births, some of our programs. We have neuroscience, cardiology, mother-baby, orthopedics, all of the things that you would look for in a hospital. We're a level 2 trauma center, for example.
So similar to Southside Hospital, Long Island Jewish Medical Center is a tertiary hospital, right? Which is, as Irene said, sort of a fancy way for saying we do the most complicated cases, and we have the most complicated services to address all of the needs of our patients. We have close to 5,600 employees, and we're extremely busy because we're technically in Queens, so we get Queens folk as well as Long Island folk into our hospital. Under normal circumstances, 583 beds is what we're licensed for. 2 years in a row, we've had 100,000 visits to our emergency department, and we were one of the largest facilities in terms of births in New York State as well. So over 9,000 babies were delivered last year at our hospital, and proud to say that is a service that we kept open throughout the entire pandemic. When other hospitals were closing labor and delivery, LIJ was taking those patients to have those expecting mothers deliver in our hospital as well.
So as we started to prepare for the pandemic, and as Anisha mentioned earlier, Northwell really partnered with Governor Cuomo early on around really Michael Dowling, our CEO, becoming a trusted advisor in relation to the planning and our response. We were one of the first in the nation approved to partially automate the COVID testing in our core labs, which is the picture below. And Anisha can relate to this with our BiPAP machine, using that as an option and creating protocols and how we can use that machine to help people breathe versus a ventilator. So getting approval for that and then sharing that protocol with others. And then finally, the example on the bottom, if you watch 60 Minutes, this physician from Michael's hospital really gave a testimonial similar to Anisha about what they were experiencing on the front line. So really just starting early on to help and guide, because New York really is a center of the pandemic and being able to support that. So from Michael and I's perspective and partnering with our executive teams in the preparations, we had to prepare for what would our surge plan look like and how would we accommodate all of these COVID patients. And Anisha mentioned supplies everywhere and how are we moving everything around, and really getting ahead of it and determining where would we put these patients, how would we make sure they were safe, where would we put our non-COVID patients, and how would we plan for that. So each hospital with a centralized Northwell system operations center really looked at how we were going to accommodate patients. And being part of a large health system, we were able to look at where could we move patients so that we could spread it out and not one hospital be more overwhelmed than another hospital. So for example, we got out east in Suffolk some patients from Forest Hills. So being able to move things around and plan strategically around how we handled it was important in the preparation.
So in addition to planning and preparing and having various levels of a surge plan that we could activate as the surge increased over time, we also had to get creative about what we were going to do with all of these patients. As I mentioned earlier, we were at double our capacity just about at one point. So where do we put all these patients and how do we deal with it? Every hospital dealt with it differently. So at Southside, they actually erected a additional bedded unit outside of the hospital, which is what you're seeing on the left-hand side of the screen. So that is a tent where patients could go that are COVID positive and be treated there. And they stood up essentially a unit there that's still functioning and in existence today. At LIJ, we're on a campus with multiple facilities. So we actually worked out a lease agreement with a rehab facility on our property, take over a floor to move our patients there. We're actually connected underground via an old tunnel, so we were able to potentially transport patients from our hospital to their hospital. We also took our lobby and made that into a secondary emergency department. We were seeing so many folks coming into the hospital that it was easier for us to triage them as they came in and either send them to the lobby, which is what you're seeing the picture on the bottom of your screen, or to send them to our actual emergency department. So we really had to come up with these creative ideas. And as Irene mentioned, we also load balance. So we moved patients around from hospitals that were overwhelmed. Once we stood up the units in the various hospitals, we had to staff them. And there were a number of different ways we did that. We were lucky enough to have outside support to help us. So we had folks from Intermountain Health in Utah come to our hospitals and support us there. University of Rochester also sent folks. At Northwell, we have Flex staff, which is our internal temp agency. And so you can sign up for extra shifts. Those folks that signed up, we redeploy them to the hospital that needed them. We also have the ability, as I mentioned earlier, to look at skill sets of folks and understand where we could redeploy them, right? So if an OR nurse came from a medicine floor 6 months prior, he or she got redeployed back to that medicine floor when our ORs closed down. And then we continue to stand up temp pools for folks coming into the organization to supplement our needs. But with that, we also expanded our normal ratios of care, nurse to patient, right? And so where we might normally be at a 1 nurse to 5 patients, that increased as the surge increased. And we supplemented it with folks we call functional nurses. Those are nurses that don't have an actual patient assignment. They're there to help support the other nurses that do. This is just a picture of our Intermountain folks. Irene and I were lucky. The 40-something folks that got sent to Northwell Health, they were split between her hospital and our hospital at a time where our staff really needed their spirits lifted and they needed fresh resources. And this team came, physicians and nurses, and they really not only lifted our teams up, they gave us that extra push to get through a really difficult time in April.
Yeah, and we got some respiratory therapists also.
We did, yes, we did.
So really, as Michael and I mentioned, our main focus around, planning and strategic, but really supporting people like Anisha and her team as they were going through this and how we're going to get to our path to recovery. So the first thing that was important was coming up with our strategy around how we wanted to communicate and as a leadership team in each facility, be present with our team members. So you can see some of the things here that were our principles and how we were going to communicate. We also, from the health system, really were ahead of the curve in having a SharePoint team site where people could go and see where they could get tested, myth busters, policies around pay and benefits, and all those things that were there to support them. We also had a leader site, so helping our leaders communicate between patients and families, just myth busters so that they could support their teams, and just things to help for virtual meetings and things like that. When Michael was talking about the staffing, in the past, with hurricanes and things like that, we were always all hands on deck. But in this case, we really only wanted people in the hospital that needed to be there so that we would limit the exposure. So we did have a lot of people move to remote work. So just making sure our leaders had tools to do that. And then finally, how do we communicate locally? So we always have a health system communication strategy, but then each hospital has its own little subculture and how they operate. So Michael and I are lucky because we're very similar and we're in the same regional structure. So these are just examples in terms of text messaging, our Facebook page, letters from local leadership, and then things to our local leadership twice a week on what they need to know, what they need to say, and what they need to do with their team members.
So communication with our team members and our leaders was key, but we also got a lot from our community, and for those of you out there who are listening, who are part of the community and not healthcare workers, if you participated in any of these things or you're thinking about it, just please know that every single person that works at these places, whether they're patient facing or not, is extremely appreciative when the community shows their support for what we're going through, and their appreciation for those frontline workers. These are just some examples of some of the support that we received. The local community by Irene raised, I think, $70,000 to support local healthcare workers. There have been endless food donations, letters and videos from school children, from adults. I can remember about 3 days into the crisis, I was pulling out of my hospital, and there are 10 people lined up across the street, just with signs. Each had a letter saying thank you, right? So that all the hospital workers leaving the site knew that people were appreciative of that. We've received flowers, monetary donations. So please know that if you're thinking of doing this, we're appreciative of it, and we thank you for that. These are some other examples of things that went on in the community. We had Patrick Lynch, the president of the NYPD PBA, come with the PBA folks and hand out food to our hospital workers. You can see him there in the front, and right next to him is our CEO, Michael Dowling, and behind him our executive director, Michael Goldberg. There have been daily clap-ins and clap-outs for team members by local first responders. So as our folks come into the hospital and leave the hospital, folks are showing their appreciation as well. And we really tried as a team to make sure that despite all the horrible things that people were seeing when they were working in the hospital, that we figure that they leave as lifted as they can and they enter as lifted as they can, go to their shift. So in addition to this, we've really tried to do our best to maintain our focus, and we'll go a little bit more into this in a moment, on employee wellness. Throughout this, really a focus on trying to offer healthy options for our folks who are on the go. We stood up stores in our hospitals for people to buy healthy options and food and supplies for people to take home with their families when they couldn't get them. We had wellness raffles. We have a meditation center at LIJ where a holistic nurse was there helping and performing different things with staff. So really wanted to make sure that our staff was as energized and as well as they could be to help on the front line.
And I think I saw a question in the chat related to chaplaincy. So for example, and I know Michael has the same thing, at Southside we have a director of chaplaincy, and really a lot of what she focused on were outdoor social distancing prayer groups for people. So
I think we may have lost Irene's audio. Does anyone else hear that?
Yes, Irene.
Yeah, I think we may have lost your audio, Irene, but maybe we'll tackle that question as soon as your audio gets back, Irene. In the meantime, maybe Michael, you can continue chatting.
Yeah, that's fine. I wonder, do I have the ability to advance the slide?
I guess
we lost Irene completely.
I guess we lost Irene. Whoops. A bit of a technological mishap. These things happen, though.
Greg, that's what we might do is when she returns, then we'll go back to where we were. But in the meantime, I know we have a lot of questions in the chat that you've been monitoring.
We do. Yeah, we do. We have a lot of questions, so we can get to those now. Yeah, thank you, Nefti. And we'll get to some of these questions now, and then when Irene gets back, we can transition to what she was in the middle of explaining. I think the first question I'd like to ask, and I think we can direct this one to Mike. Someone asked there are COVID areas and non-COVID areas inside a hospital. This individual was worried about air conditioning systems and whether that could transmit the virus. Is that a possibility that air conditioning systems could do that? And what do hospitals do to make sure that the virus can't spread through those air systems?
Yeah, so the first thing I will say is caveat here, right? I am not an infection control, right, practitioner. I'm an HR practitioner and hospital administrator, so maybe Anisha will chime in a minute. But, right, we have all different types of patients coming through our hospital all the time. There are patients on droplet precautions, as we call it, just as they are with COVID. We have special HEPA filters in our air conditioning system, right, and such. And so very similar to how we would treat, I think, a TB patient or anybody else on droplet precaution, right? And so we have those systems in place in our hospitals to make sure that all of our patients are safe from the spread of things like that.
So I can chime onto that. So for the COVID patients and the TB patients, we have negative pressure rooms.
Yep.
So air conditioners are positive pressure, so they throw the air in, they don't suck it out. So when the air conditioners come through, it goes through the filter and then the air enters the hospital. But all the COVID areas are negative pressure. So the room's doors are closed. If they're, the doors are there, the main door will be closed and they're negative pressure. So the air gets sucked out, goes through the filter and then outside. So recirculation of the air is not happening, and these two are different systems. So there is a safety mechanism.
Good question.
Excellent. Thank you. Yeah, thank you very much. We also have a really good question here, which is, this is for any of the panelists, so maybe we'll speak to both of you on this. The question is, what changes do you see in hospital patient care that you anticipate will stay in place after the crisis abates because they're simply good ideas and good improvements? Maybe we'll start with Anisha.
So for respiratory, a lot of it changes, right? Because the uncertainty of is the patient COVID or not when they come through the emergency door, and you don't want the nurses and the doctors or the other patients in the emergency room to be exposed. So there's gonna have to be some systematical ways of how are we gonna triage patients, because right now the way our emergency room is, everything is not single bedded closed door, right? They come to the lobby, they sit there, they go to registration, the waiting area is open, everyone's just sitting next to each other. So a lot of that stuff is gonna change. In terms of our workflow, respiratory therapists have, like, just for an example, we use a BiPAP mask. So the circuit is connected to the machine. This mask has little exhalation ports right on top, right? So when the air goes in, patient breathes in, then the breath comes out. Now, for the COVID patients, we cannot have that mask. So just an example of like every little bit of details that we are going through to how do we prevent this in future? How do we make it very less possibilities? How do we decrease the possibilities of the spread going through every single machine and the piece that we use in respiratory wise to decrease infection? So now we have to get masks that don't have the holes and have the other ways of exhaling through the filter. So that's just one example. Same thing with suctioning the patients. If they are COVID positive, or if we don't know if they are not in future, how are we going to prevent it? So for respiratories, it's going to be a lot of changes, and a lot of ways of we do things are going to really change. And system-wise, maybe Mike can answer how, administration-wise is going to affect.
Yeah, I'd be curious to know how the administrative side is handling these things and what innovations have been discovered.
Sure. So I think, well, first of all, I just think our pre-surgical testing protocol will change as well. So when patients come in, we're going to make sure that we test them ahead of their surgeries, 48 hours, unless it's emergent surgery, right? And they're rushed into the OR. So there are protocols like that that now will be in place to ensure that not only they, but also our team members are as safe as possible. And then I think administratively, right? Hospital system in general and hospital systems in general, I think many shied away from remote work, quite honestly, because we're a 24/7 operational facility, right? And I think we're now exploring, and we've sort of tested and have data about how we can work remotely and still deliver the same standard of care, right? And so on the administrative side, that's definitely something we're exploring. We've also taken precautions at places where our staff interact with other folks. So in some of our HR offices or ambulatory offices, putting up plexiglass to make sure that there are not droplets exchanged, right? When people are interacting with each other, paperwork is slid underneath a little door in the plexiglass. And so while that was something that we would just see at gas stations, right? That is now a technique that we're deploying at our hospital and some of our ambulatory sites as well.
Wow, very interesting. We got another great question here. In regards to, it's a little bit technical here, but it's, have any of the panelists seen an increase in kidney damage among COVID-19 patients or experienced a shortage of dialysis machines? Maybe we'll start with you, Anisha, from what you've seen.
Yes, that's definitely, you know how just everybody talked about ventilators and ventilators and ventilators, and people forgot to talk about all the other resources and the machines that we're gonna need. So I think in my hospital, I have the estimate number of how many bedside dialysis machines that we have. I think it's about 26 or 30 or something like that. Because most of our patients, we bring them to dialysis unit. But because we were trying to minimize the transports from unit to unit to prevent, you know, the spread, 26 machines. So it comes down to, and it's definitely kidney damage, to answer the question to begin with, because when your body can't absorb the oxygen, it's multi-organ failure. So everything from your liver to your intestine, your stomach, kidneys, everything gets affected. And then the longer you are on the machine, on a ventilator, or longer you are hypoxic, we call it hypoxic, less oxygen in your system, the damage is gonna just get severe. So yes, kidney damage, and then they had to create guidelines of how are we gonna distribute the dialysis machines at the bedside? How are we gonna move certain sort of stable people to dialysis unit? And so the renal department had the whole guidelines just the way anybody else, just the way we did. So even for ventilators, right, we prepared for worse. Thank God we never got to a point where we did not have enough ventilators, but there was definitely like who gets a vent and who doesn't get the vent. And we waited till very last minute to, because nobody wants to talk about it, right? Why would, like, it's something that we never wished that it would happen. Like they talked about how we converted our BiPAP machine into ventilators. So we'll never get to that point. So all these guidelines were there, and yeah, so dialysis machines were definitely short, the ones at the bedside.
We saw a surge in the need for dialysis here too, not only for the inpatient population. We also found that symptomatic outpatients that were going to typical dialysis clinics were diverted back to the hospital. And so we were getting our patients that are in the hospital on dialysis and then patients on outpatient dialysis who may be showing some COVID-related symptoms pushed back into the hospital. So we had a huge staffing need that came in sort of a second wave. First wave was respiratory therapists and nurses and folks at the bedside for inpatient. And then we had that dialysis need on the back end as well.
Wow, really interesting. We got another great question here that's not quite as technical, but a little more about yourselves. The question is, what drives all of you? The person asking the question said that they can't imagine how you've continued to function during these stressful times. And then are we prepared for a possible reoccurrence of this in the fall? Anisha, how about yourself? What drives you, and are we ready to handle this again?
So what drives me as a person, I always wanted to make a difference, but I also know myself that I get very emotional about it. So I don't want to be at the bedside my whole career, right? So that's why I did my master's and I'm going into public health. I want to be in a place where I am able to influence the policies with my clinical experience, because there are certain times you see that, you know, people making decisions are not clinical, and then sometimes you're like, this doesn't make sense, like why would you decide? But it's not their fault because they're not clinical, and if they don't involve the frontline staff or if they don't have the clinical experience, the policies are not going to make sense. So what drives me is that I want to make a difference where it's going to impact, right? So that's why I love Baruch's logo, impact. I want to make an impact. And what drives me is that I cannot not make a difference. Every day I have to do something good. It's, I have to meditate to get rid of my stress, to maintain my sanity, and process my emotions. Like I said, I, get affected when I see someone cry, I cry. It's just, and then I go to the bathroom and I cry. I don't cry in front of people, right? So, so it's just that as a human being, I actually love being a human, and I want people to feel that there is so much potential in human beings. We should not limit ourselves. And I think that comes from Indian culture. I grew up in India, so meditating, yoga, human potential, infinite sources of energy and the God, and I believe in higher power. So that drives me. It drives me to make a difference. I want people to wake up, do your best every day. Life is not that bad. We live in America, the best country on the planet. We need to stop complaining about little stuff. So when the pandemic happened, you know, a lot of respiratory therapists, and I want to share their thoughts. And I said, you know what, I'd rather be at front line than a lot of other people, because I know I'm going to give my best, because I know I'm going to protect myself. I'd rather be the respiratory therapist who's going to suction the patient versus the doctor and the nurses who are not prepared, because I know I'm going to do everything to protect myself and for the patient. So that's a sentiment in my team, and my team actually drives me. I do a lot of stuff. I push myself to go above and beyond because they're working so hard in a respiratory care department. But as a person, it just drives me to be the best version of myself every day.
Thank you very much, Anisha. That's inspirational. I want to welcome back Irene. We got you back.
Nice.
I lost my Wi-Fi.
You
Had
know,
to get creative.
I hear you.
Had to
These
get
things,
creative.
these things happen. We totally get it. So yeah, why don't we pick up with sort of where you had left off, and then we can get
Sure.
back into some of the Q&A.
Sure. I think we were just talking about the focus on wellness, and
Yep.
then I don't know what, and like I didn't know what the questions were. So Michael, do you want to take this?
You
Yeah,
know
I'll
what?
just go through a couple of these, and it's perfect timing, Irene, because we're also going to prepare to steal Anisha from our competitor, because she answered all the questions really well.
I just wanted to quickly point out that it's currently 7 o'clock, and I know that throughout the country and throughout the world, a lot of people have been honoring those who work in the healthcare industry at this time, and I just wanted to acknowledge that with a little applause here. I know everyone is applauding in their homes. I'm going to use the reaction for my applause as well. Yes, thank you. I see some folks are putting up their applause signs.
Very
We
nice.
appreciate all that you guys do, so thank you so much.
Thank you. So we'll go through this quickly so we can get to more questions, but just wanted you all to understand that sort of, as we're going through the struggles of this pandemic and the staffing issues, we wanted to make sure that our staff had resources they need to make their lives as easy as they possibly could be when they were leaving, right? These are folks that are leaving their families, their children, come to the site and be on the front lines. And so as part of our Northwell initiatives, we had housing accommodations for folks who were living with older family members, immunocompromised family members that they didn't want to go home to after working in the hospital. So we had housing options there. We had, next page as well, we had shuttle options for folks who needed transportation to work. We had daycare options, babysitter reimbursements, all these things to make sure that their lives outside of the hospital were taken care of as best as we could throughout this crisis. We also have a recognition system here, and our team members are able to donate points, which can be redeemed for various prizes and gift cards to each other to recognize each other. Great recognition portal that we have that we use a lot. And then we've also added on to some recognition campaigns. U.S. News and World Report is doing a Healthcare Heroes profile. The system has nominated a number of folks for that. I think my hospital had somewhere between 50 and 75 nominations sent to U.S. News, and those nominations come from healthcare workers for healthcare workers, which is a really nice way to recognize folks in profiles. And they weren't just respiratory therapists and RNs, they were our environmental service folks who made sure the rooms were clean, our dietary folks who were delivering food to our COVID patients, our engineering folks who ripped walls down to make sure we had units stood up to deal with the 900 patients that were in the hospital. Our IT team made sure that the technology infrastructure was there for us to update our medical records and such.
So, this was Southside. You might have, if you have News 12, you might have seen it, but really around the spirituality, this was a grassroots campaign by our team to create shirts and really have a day of hope and prayer right in the middle of this. So it was, I think last month, where all the staff came outside and just had that day of hope, just to know that we're going to get through this together. And most recently on Monday at LIJ, they had really a memorial around the sacrifices made by all and held a candlelight visual. So if you look at it and put in perspective, it was right in the middle, having this moment to pause and hope and say, we're going to get through this and we're supporting each other. And then now kind of remembering the patients we lost. You know, I think at LIJ they lost a team member, so being able to remember that as well. But, you know, during all of this, it was really important that we help team members celebrate the good things when a patient was discharged. So I don't know if you were able to see on the news, at Southside Hospital, we had the patient who was the mother that was on a ventilator and met her baby for the first time when she was discharged. So that was really touching, and I got to be there for that, and I'll never forget that day. But if you look on the side, you can see celebrating our wins, and each hospital has their own way they call it, but really it's about the clap outs and everybody coming together to celebrate when something really good happens. And at LIJ, they celebrated not only their 1,000th COVID positive discharge, but most recently their 1,600 COVID discharge in the upper right corner. And on the bottom, if you've ever heard on social media of the site Some Good News, where they report good news, LIJ was featured on there. So finally, our path to recovery, Michael, take us home.
Yeah, sure. We'll wrap up quickly so that we can get back to the questions. But the truth is that yes, we're on a path to recovery, but the path is somewhat unknown, right? And we're leading sort of what I'll call this sort of, it's two paths, it's bipolar, right? We want to continue to move back to operations as normal, right? We're also being cautiously optimistic in case we see a resurgence of this, right? And we want to make sure that we're prepared for that as well. So as we're doing this, we're now looking at how do we help our healthcare team members and our team members recover, right? And start to heal from what they've experienced and what they've seen. We recently sent out a well-being survey to get some feedback from them. We're offering various services to those individuals to continue to help make their lives easier. Simple things like coming and getting a haircut while you're at work. Right? I don't actually have that issue, but some of our team members do. But simple things like that, right, to just help make life easier. We also are proud to say that we're as a health system, for those folks that worked on the front line throughout the pandemic, will be receiving a Healthcare Heroes bonus, a combination of a monetary lump sum and days off that they can use, and that will carry over from year to year, so they can take the time to recharge, be with their family, and start to recover from that. Go next, Irene. We also have services on site and services for them to call into. We have our Emotional Support Resource Center where they can be connected to system chaplains and our EAP social workers, employee assistance program social workers, 24 hours a day, 7 days a week. At my hospital, we have a designated room for employees to go in and close the door privately to be able to make that call. And then we also have an on-site social worker 7 days a week at shift change in our chapel that employees can go to for one-on-one counseling and to learn more about the resources that we have across the system. And so our system has stood up these great resources for our employees to use. Go ahead, Irene. You can go. You can click next.
So that's pretty much it for us. You know, we're at the point where the curve has gone up. We're getting a little bit more stable, but we're still in this. So when we think about the path to recovery, and I know Anisha will agree and Michael will agree that we're still in it. So we're on this journey. We're doing everything that we can. We encourage you to continue to take precautions. We have a path toward the future, but like I said, we're still in it.
This week is Nurses Week, so if you know a nurse, say Happy Nurses Week. 2020 was named the Year of the Nurse, I believe. So please thank a nurse or a healthcare worker, respiratory therapist, EVS worker, food services person. Let them know that you care.
Thank you so much. Great insight from all of you about how hospitals have been handling this, and Anisha, how you on the front line. So another question, with the little bit of time we have left, we'll try to get to the remaining ones. Anisha, what was the greatest frustration you had during this crisis, and what type of additional things could have made this better for you and your patients?
My frustration wasn't a bigger deal. I don't usually like negative talk, right? So people constantly panicking about, we're not gonna have PP, we're not gonna have this, what we gonna do, so that like constant nagging and creating the hysteria. So some of my teammates, when they go out and they hear, and when everybody else is panicking, they come back and they're like, Anisha, are we gonna be okay? And then, you know, obviously I said, I'm telling you, because in America, we're used to abundance, right? I go and I throw gowns like it's nothing. Oh, two drops on the floor, who cares? I put them in the garbage. My N95s, there is no count. I go one patient after the other, I use a new N95. So now I'm given one a day and I'm panicking like, oh my God, what's gonna happen if this becomes dirty, or if I drop this, or am I gonna have another one? It's all the downward spirals that people were going into it instead of staying calm. That was my frustration. But bigger stuff don't usually bother me because I know we're gonna handle it well. And we had a lot of support, and like Northwell has, NYP also have a enterprise, and other stuff is being taken care of that I don't have to worry about. So handling people and keeping them calm was the frustration, because creating this uncertainty on top of the crazy uncertainty we have, it was so not necessary. So, you know, I think in 2 weeks or so, people kind of got the hang of it, like, okay, you know what, we'll survive. We're going to have at least one a day. Let us calm down. So that was my frustration.
Yeah, we got another question that I think would be applicable to Mike and Irene. The question was, if someone is interested in a non-clinical career opportunity in the hospital, how would they know that those types of positions are available and when they should apply? I think the HR folks would be perfect for this one.
That is correct. Irene, you're still on mute if you were talking. But
No, you go for it, Mike. You know, you got this.
So we have a careers website. Just search for Northwell Careers. It will pop up. All of our clinical and non-clinical positions are there. There are plenty of opportunities in the non-clinical side. I don't know, in terms of timing, is that what part of the question was? What is the right time? So I would say that really depends on the person, right? We're such a big health system. There are opportunities that come up every day, whether that's finance, marketing, HR, right? Our foundations for fundraising. And so it's really about when the person's ready to join, and if they want to join an organization that's connected to a tremendous purpose. And that goes for us, that goes for New York Presbyterian, right? We all are lucky enough to work for organizations that have that purpose. So I would say there's no time better than now. If you're ready for it, go ahead and do it.
Actually, if you have your MPA, there is a quality research department at NYP here in Queens. Like, they started a couple of years ago, and that's been growing, and a lot of them have MPA and MPH. So if you are interested in collecting data and research and putting posters together and presenting, that's definitely a non-clinical department that you can take a look at.
Yep.
Interesting. Very cool.
There's two other things I would add, if that's okay.
Sure.
The first would be LinkedIn is your friend. So you may apply for jobs online, but it's important that you network with people in the organization that you're trying to become a part of, because they'll inform you. And Northwell also has a management associate program that they recruit for, who are healthcare professionals. Go for the MPA, and it's a 2-year program where you go through all the functions of healthcare administration, and then hopefully once you graduate from that program, employed that whole time, you assume a role within the organization.
Very cool. One other question, we'll try to get to it quickly. prior to the pandemic, many organizations often run crisis scenarios. Were any of your hospitals running a crisis scenario to determine readiness for a situation like this? Or where did this compare to those crisis scenarios? Anisha, maybe we'll start with you.
Sure. So I don't think anybody ran for pandemic. I've been at NYP for how many years now? 12, 13, 14 years, right? There was never a pandemic emergency scenarios, but we definitely have an emergency preparedness department where they have there's certain amount of stocks that they have, like I know in NYP in the city, because it's in Manhattan, they have a huge warehouse where they stock up for, I think, 6 months to like a year worth of supply or something crazy like that, because they don't have, you know, access. Their trucks and everything can be delivered just the way we have it here. So every place has its own, but for pandemic, preparing for when we have, actually, I'm going to give you a crazy example, which was pretty scary, and it happened to a lot of hospitals in New York. When we are running 50 ventilator, that's our capacity. There is a bulk oxygen system, which is a liquid oxygen that turns into gas, right? So that's the whole engineering department, mechanical stuff. And when your hospital's, let's say, capable of running 100 of machines, and then you're running 200 on top of the crazy demand in oxygen, that system was crashing. We had to get an emergency backup, and it's a very complicated system to attach to it. So in the meantime, to prepare for it, we usually have 10 big oxygen cylinders. We had to get 200 of those. And now we have to find space for it. How are we gonna secure it? How is that safe, right? Because it's like a fire hazard. So nobody prepared for something like this. We were prepared at, let's say, 50% of the rate. And in respiratory department, we do, we're a little obsessed, my boss and I, so we do stock up for at least a month worth of supply, just for our anything could happen in flu season, like, you know, our ER peaks is one of the craziest in the Queens. So we were prepared a little bit better than other areas, let's say, for, you know, no one stocks 10,000 yellow gowns or PPEs, so.
Right.
Yeah.
I think we've lost Irene again, unfortunately. She's kind of was cutting in and out. These things happen. Wi-Fi does not always cooperate. But, you know, I think in the interest of time, I'm going to cut to Neftali now to bring us home.
I just want to say thank you, Greg. Thank you to all the guests that were alumni guests that asked questions. This was very informative. And just before we leave, the last questions I'll give to Anisha and Michael, and hopefully Irene can come back on. What is the next great challenge that you're anticipating as this battle continues in the weeks ahead?
So rolling back is not easy. Going forward, when we say we're gonna stop, you know, using this, and this, and it's just stopped, right? Now going back, half of it is COVID, half is not COVID. That's a huge challenge in itself. For respiratory therapists, because we cover multiple areas, now how are we gonna separate the areas where with the same amount of RTs? So everything from logistics to the assignments and clinical care, it's very challenging. Every day we use our brain so much, like which part and which pieces, and respiratory is crazy in terms of the adapters and the connections, and we have like gazillions of them. So we're just gonna have to figure out what is the safest way for the patients and for the RT. So that's a bigger challenge to roll back.
Thank you. Irene, one of the last question that we asked, and I said, let me get you before something happens again real quick.
We've been blessed with all the outpouring of media.
Oh, I think you're kind of cutting in and out, Irene. Unfortunately, I think.
Go ahead, Michael.
All right. So I would say there's a bunch of challenges. Let's put the caring for our team members aside, because we talked about that a little bit. Although that's going to be part of road to recovery for us. I think we're also anticipating a new surge of patients coming back to the hospital who are not COVID patients, but are coming for other issues, right? That held off, and now they're in worse shape than they were 2, 3, 4, 5 weeks ago, that avoided the hospital. And in addition to that, new surge of surgical cases once our ORs continue to open and expand. So we have to prepare for that. And we also have to prepare for letting visitors come back into our hospital. Right now, this is the employee hospital, just our employees here with minimal amounts of visitors. And that's going to create a new challenge for how we screen those folks when they come into the hospital, visit loved ones and family members.
Excellent. And we lost Irene again, Neftali, I believe, unfortunately. But you know what? That just tells me that we'll have to do this again in a few months and reassess where we are. Yeah.
Absolutely.
Yeah.
Let me say again, thank you to our panelists. This was a great, great presentation. Thank you for allowing us inside your world for a little bit. And as I close, I will say, Gandhi, I believe, said that the best way to find yourself is to lose yourself in the service of others.
Yep.
So I thank you for your courageous efforts right now and your service during this time.
Thanks for the opportunity.
Thank you, Neftali. Yeah.
Thank you, guys. Really appreciate it. And thanks to all of our alumni who signed on today. Thanks for your questions.
Thank you,
and
everybody, for listening in.
Yeah, thank you, Greg.
Thank you, everyone.
Thank you.
Take care.